Hey, Clay Smith, JournalFeed. We've got that would be 10. We got 5 great articles for you this week on JournalFeed. Okay, article number 1 was written in Clinical Infectious Diseases, and it was about the use of Nirmatrelvir, ritonavir, or Paxlovid, on patients who have advanced kidney disease, including those on dialysis. In fact, most of the patients in the study were on dialysis, and what they found was that a modified dosing schedule was absolutely fine and had no adverse events in these patients. The usual dose was 300 milligrams of Nirmatrelvir on day 1, given only once as opposed to BID, followed by a reduction of that dose by 1/2 to 150 milligrams of their Nirmatrelvir component, given once daily for days 2 through 5. So that was the most common dosage adjustment for renal failure. And it turned out pretty well. This was just a single-arm prospective study. It would be nice to see a larger study, but there you go. I think it's pretty safe. The next article we covered was a retrospective review, and it was done out of the Cleveland Clinic. It was also on Nirmatrelvir/ritonavir or Paxlovid, as well as molnupiravir or Lagevrio. It found that in this retrospective study of patients, over 68,000 patients, the usage of Nirmatrelvir or molnupiravir was associated with a reduction of both hospitalization and mortality at 90 days. And what's interesting is, in the past, molnupiravir has been shown, such as in the panoramic randomized controlled trial, to have not been effective and even maybe harmful. But in this study, there was a very strong association with reduction in hospitalization and mortality for not only molnupiravir, but also Nirmatrelvir, which we kind of already suspected. This is important because it's now in a different era in which most patients have had the illness or are vaccinated. And we're also seeing this effectiveness remain despite it being an era of different subvariants of Omicron. So these drugs continue to be effective, or at least they are associated with a reduction in important patient-centered outcomes. So I'm going to continue to prescribe them in appropriate patients. The next article was a new clinical policy guideline published by the American College of Emergency Physicians on acute ischemic stroke patients and their care in the emergency department. They were asking 4 key questions. Number 1, are there pre-hospital stroke scores that could predict large vessel occlusion? Turns out there are. The Los Angeles Motor Scale and the Rapid Arterial Occlusion Evaluation Scale, RACE. I don't know how they get RACE. Anyway, but yeah, turns out those were okay. Level C evidence. The next question that they were asking is, can we use CT perfusion or MR perfusion imaging to predict which patients might benefit from endovascular therapy? And there was a level C recommendation that you could do that. The third question was, is tenecteplase as good as alteplase for the treatment of acute ischemic stroke? And turns out it is. The final question was, are there any tips or tricks that you can get from the history or physical examination that would predict acute ischemic stroke in patients that are presenting to the emergency department with vertigo? And they said, yes, there are. Specifically, they got into the use of the HINTS exam, but they reminded us that if you're going to use HINTS, you should be well trained and checked off on using HINTS properly, because if you're not sure how to use it, it can actually cause problems. Next, we covered an article in JAMA Open on the use of a new app to help walk you through the resuscitation of a pediatric cardiac arrest. And they found that the residents that in training that use the app actually ended up doing better than if you had sort of a paper guide, to walk you through PALS, the AHA PALS, or if you had no guide at all. Turns out that's great, but I can't find the app anywhere. Does anyone know where to find this app? It's called PD App Arrest. Anyway, it was made by authors or inventors in Italy, and I would love to learn more about this app, but I can't find out where to download it. Please leave a comment if you know how to get this app. And then finally, we covered an article on anchoring. Anchoring is a form of bias in which the thing that is on our mind that we see initially is anchored in our minds, and then we don't think outside of that and consider a broader differential diagnosis. And what they found in this VA retrospective cohort study was that if it said congestive heart failure on the triage, that physicians were less likely to explore the possibility of other causes of shortness of breath, such as pulmonary embolism, by doing specific testing for PE. So what is written in triage is important, and it's not triage's fault to include that information. What matters is what we do with it. Don't let it bias your thinking, and certainly don't anchor on it. All right, that's what we got for you this week on JournalFeed. Go to the blog, journalfeed.org, and you can sign up, subscribe, and get these article summaries delivered to your inbox every morning at 5 a.m. Central Time so that you can stay up with emergency medicine literature, because it's not easy, but this makes it super simple. We are hoping to help you to read less, learn more, and save lives.